Hello everyone, and welcome to CK Med. My name is Clark, and I'm going to be taking you through adult kidneys and renal and development and pathology today. To start things off, it's important to know where the kidneys are and where they're oriented in regards to. And so we already have talked in our abdominal video about the different branches off of our aorta. Our descending abdominal aorta gives off different branches to, as it comes down out of the chest, it gives off branches to our foregut, our midgut, and our hindgut. But it also gives off vessels such as our left and renal arteries. And you can see that actually right here in these pictures right here. This is our left renal, and this is our right renal artery. And then you can see that the venous drainage from those also come back from the kidneys on the right and go directly into here, and on the left that go directly into here as well. And then, as we've spoken before, there are some other aberrant arteries and blood supplies. If we discuss this in our pelvic and perineum section, our pelvis and perineum is that our gonadal or our testicular or ovarian arteries veins actually drain back into the renal on the left side. You can see that this is for a male in this particular picture. The testicular also, if it's in a female, it's ovarian. And as a general group, a more broad concept is they're called gonadal veins on the left side drain into the renal vein before going into the IVC. And this is a place that we can get nutcracker syndrome. And we discuss this as well from superior mesenteric artery, which I'm circling right up here. If this goes over on top of here and squeezes and squeezes on this left renal vein, we're going to occlude blood supply draining from these areas in the kidney, the adrenal glands, and then you will see it swelling down in the testicles in a male, and this is called varicocele. Varicocele. And that's one pathology you might be able to find in males that have this syndrome. And so the kidneys, where they lie, we'll be discussing where they lie as in regards to what ribs and such and what organs, but it's important to recognize that the kidneys are also found in the abdomen. And therefore, they're an important cause of abdominal pain. And usually, actually, what it's described in multiple choice questions, so when you have a vignette of somebody, kidney pain is also mentioned as flank pain. Flank pain just means on the sides of your abdomen, sometimes even on the back side of your abdomen. And those are cases of kidney stones, for example, or pyelonephritis. All those things will lead to flank pain. And you'll also can have paravertebral pain if it's involving the kidney itself, and we'll be discussing that as well. And then once we get into the kidney, so the renal arteries and the renal veins are the blood supply and drainage, but also you need to know a little bit more detail. Now, this comes down to a little bit of histology more than anatomy per se, but that is a very important concept. As you go through each of your terms, you're going to get to term 5, and you're going to have to review all this material. And this will, again, come up there, so it's going to be on quiz questions, so why not learn it now and never forget it? In addition, it does show up on stems in questions for step 1. Now, step 1 is very well-rounded, and so it's very clinically oriented. However, it uses basic sciences for your STEM questions in order to ask a clinically relevant question. And so they could put it a second order. They could say, okay, well, if we follow the renal artery that comes in, what is the next thing? Well, the next as a dividing branch are going to be your segmental arteries, whether they're superior, anterior, inferior, that doesn't matter. Just knowing that the segmental arteries is the next step. So you go from renal artery to segmental artery, and then from there you go to what? Well, that's going to be your interlobar and then interlobular and arcuate arteries. And so interlobar and interlobular isn't mentioned here, but it's also another way of describing our arcuate arteries are here. They make this kind of arc for each of the pyramids, but then our interlobular are the ones that are going to be coming off of there. So if we do this, we have interlobar, and then we have arcuate, and then we have interlobular. interlobular as the order. And then following interlobular, what do you have? Well, this is everything pretty much renal physiology. That's going to be your afferent arterial, and then that's going to be your glomerulus, and then your efferent arterial. And then it will follow the same trend backwards. So if we started and ended down here in interlobular, then it'll go interlobular vein, arcuate vein, interlobars, segmental, and then renal vein. The one other thing that comes off for your efferent, remember, you have to supply your parenchyma of your kidney, right? So that's going to be your vasa vasorum. So just that's an important thing that comes off of there, or also we'll continue down the way we were just saying. Okay, and so those are kind of important branches to remember. The order, what happens, because I could say, oh, this person has an infarction of your interlobular artery. What is the next blood supply that is not going to get blood? And that you need to remember, oh, wait, that's my afferent arterial. Or what's it says, oh, well, what part of the kidney is going to be importantly affected? Well, obviously, our GFR is the most important thing of our kidney's function. And so where is GFR occurring? That's going to be at your glomerulus. So certain things like that. Renal physiology is pretty much all around this section and then tubules. However, for anatomy purposes, knowing where the kidney lies, what organs are around it on the left, and what organs are around it on the right, that's a liver. And this is a spleen. And then where they're located as far as what rib spaces are you going to see the kidney kind of overlaying, that if I have a fracture of this rib, that this could puncture my kidney and damage it. So all those things are kind of important to know for kidney anatomy. So let's talk about that very specifically. So we have our kidneys. We're actually looking at a person from the back side. So this is where their spine would be kind of running along. And we have different muscles that kind of overlay the kidneys on the back side, such as our upper part, which is overlaid by the diaphragm, as mentioned from here. And then we have three muscles that overlay and lie on the more inferior posterior part of the kidneys. And so this is just telling me where the kidney is specifically laying on. What muscles is it laying on if this person's on their back? It's going to be on their diaphragm, because remember, the diaphragm kind of sneaks in and slips in, it tucks its covers in behind the kidneys, and so that's why the diaphragm is here. But then you have other muscles like your psoas muscle, which is super important to know, not necessarily for kidney per se, but it's very important for abdominal stuff, and we've discussed this before. But then you have some other muscles that's not really that important. But what is important is what are the other associated organs in this area? Because when you have rib 11 and rib 12, right, this is the last rib, these are called false ribs because they don't have cartilaginous input, and they're floating ribs. And so with rib 11 and rib 12, if I were to fracture at this height, I could damage my kidney. Makes sense. That's what's laying over right here. And then on the right side, remember that we have this giant liver that comes down like this, and this is the way that the liver kind of lays down, and it pushes down our right kidney. So the height of the left kidney is higher than the left kidney by about one rib space, almost one rib space. And so this is important because I could say, oh, well, if I have a fracture of my 11th rib, remember, on the left side, I can damage my kidney. But if I have a fracture of the 11th on the right side, I'm not going to damage my kidney, most likely. I'm actually going to hit my liver directly. And so that is actually super high yield to know for rib fractures on the back. And these are floating ribs, and so they're very easily fractured. If someone gets hit on the side, maybe they're a boxer or something, somebody punches them in their flank. All those things can damage these organs. But it's also important to know on the left side, if I have a rib higher than this, so actually rib 10 instead, the one that's running right here, I have a spleen that overlays right here. And so at a height of rib 9 and 10, those are important to know as they're the ones that involve spleen. So just imagine this scenario. I have a 25-year-old male comes in after trauma from a car accident, T-boning on the left side. So now you were thinking, okay, what trauma is happening on the person's left side of their body? And he has severe abdominal pain. Okay, great. That doesn't really help me because that's super basic. Well, on physical exam, he has severe tenderness. He's very rigid. He's guarding. He has rebound tenderness. He really doesn't like you touching his abdomen. This is a sign of peritoneal inflammation. Either he has had an infection in there for the last couple days, or it's blood or some sort of fluid down in his abdomen, right? And we then have to figure out where is the fluid specifically and where is it coming from. Well, if they say, oh, well, ribs 9 and 10 are fractured on the left side, where is the source of bleeding? Well, that is very easy to kind of put together because you use anatomy, 9 and 10, on the left side are associated with the spleen. And it makes sense that because the spleen is so vascular, it's a very vascular origin, it's just a sac of blood, pretty much. If I pop this open with one little sharp rib, of course, I'm going to be bleeding into the peritoneum a lot. And that's going to irritate it, and that's going to cause severe abdominal pain. And you have just answered a question on your exam because that is exactly how they write that one for the spleen on the left-hand side, ruptured spleen. And then on the right side, they'll do the same thing. It'll be more of right upper quadrant pain. Now they're going to have this because the liver is so large. Yeah, you might have some abdominal pain and some bleeding. Because the kidney is so large, it takes it absorbs its blows pretty well. So you might have a localized bleeding or hemorrhage in the kidney. Obviously, you need to do surgery to fix that, but the pain might be more localized for kidney than it would be spleen, because spleen just spills out everywhere rather than what the liver would do. Okay, so that's pretty much all it takes for kidney involvement. But let's go ahead and talk a little bit about embryology before we kind of wrap up this video. So renal in embryology, you might be looking at all these terms and you might go, ew, Clark, why do I have to learn what a metanephric mass of intermediate mesoderm is? And why do I have to learn all these grooves between lobes and straight collecting ducts and tubules and mesenchymal cell cluster and stuff like that? Well, some of this actually you don't need to know. But some of it you do need to know. You can actually associate very easily and not get super confused about it. Don't ever treat embryo as if it's some new language or some new topic and new material that you've never seen or can never think your way through. Because if you do, you're going to get very confused and you're going to hate embryo. The purpose of embryo is to help you enjoy anatomy. That is the purpose of embryo, is to figure out why are things placed where they are, what made those things, and then when I have a baby that comes in with an abnormal thing that should have developed, at what point or where or what material should have formed properly that didn't. And that's all you need to really get from this. Sometimes there's a few things that are important, like time frame. For example, when do you see neural tube defects? Well, that's like by week 4 or day 28, you're going to only have neural tube defects forming before day 28. After day 28, there's nothing you can do to fix it, and you're not going to form neural tube defects after that point. It all happens before. So certain things you might have to know time frame, but it's very almost 2 or 3 things actually overall in entire body embryology for medicine that you actually need to know those dates. But everything else is sort of, do you understand the broad concept, and then might know a couple of the terms or what they mean sort of, and be able to identify them on the STEM question or in the answer choices, which is what I want to kind of cover with you today. So we have a baby right here. Here's a little baby, and he's growing, and we see all these different structures in here. So we see his mouth. So here's his mouth. And his mouth is going to go down esophagus, and here's a little stomach right here. And then here's some of the small intestines that come all the way down here. And then eventually part of the small intestine, large intestines, they're all going to kind of come out here, and they're going to outpouch. And then they're going to twist and twisty twist. This is an important thing for abdominal development. And then they'll eventually come back in, and they'll be there in their appropriate location. And that's why you have your small intestines that end up in the right quadrant, and then you have the large intestine around it. So you can see that we have spiraled around, and this is a counterclockwise kind of term. And so that's actually why we do this, so that the organs are associated in this way. So this is large intestine, and this is small intestine. So if you ever wonder why we have this random rotation, it's actually to form the normal location in adult anatomy. That's what's happening. So then down here, we have this kind of sac that comes in to this area that ends up also outpouching here. And this is called your, well, the end here is called your cloaca, and this is pretty much called your allantois. And eventually part of it will involute this part right here, and this will become your urachus. And if you have watched my videos from the abdominal wall, we talked about urachus for a particular type of cancer. It's called adenocarcinoma of the bladder. And this is adenocarcinoma of the bladder is found on the dome of the bladder, which makes sense because it comes from urachus, and urachus is going to be the tissue that closes off at the top of the bladder to make it a bag of water, as opposed to a sinus of water and have you urinate out your umbilicus. So we don't want that in babies. That's what usually happens when we have that pathology. So we have the bladder attached to the outside. Now that's normal in a baby, but is abnormal once the baby has been born. Okay, so let's break some of these things down. So let's talk about this kidney up here. I'm going to kind of emphasize and redraw this over here. So we have these little tiny bud things at the top, and this is called pronephros. And this is actually one of the first things that starts up. It's the basic, it's almost, I would say, the first single drop of urine that the baby makes goes through the pronephros. And then we don't use it after that point, because now we've made a moderate urine making machine, and this is called your mesonephros. And in your mesonephros, you have two important things. You have kind of the gills, and this is the part that's kind of filtering the blood and also putting that blood, filtered blood, into one single tubule. And I'm going to actually draw this sort of three-dimensional here, and one single tubule. And this is kind of the primitive collecting duct. If you remember your renal physiology, this is the collecting duct. And we have this little filters, sort of like the gills of this original kidney, that then filters into this tubule. Now, we don't want a kidney that has gills, so eventually this will also go away. This went away after we made the first drop of urine. This goes away after we made the first 20 drops of urine. Obviously, I'm kind of exaggerating the number of drops. It might be more, might be less, I don't know. But just goes to show that this is sort of a primitive kidney over here, and this is sort of like a little bit better, but still sort of primitive. So we end up getting rid of all the gills, but we keep the tube. So now I'm going to redraw this tube. So let's say we keep the tube, and the tube comes down to this sac down here. Here's my little sac. This is my bladder. Okay, and from my bladder, usually what was happening was I had an opening to the umbilicus, and I also had this kind of blind-ended pouch right here, that kind of outpouched. And so here's what my bladder normally looks like. Here's an outpouching, and then here's the skin. This is the skin. Outpouching that does not connect, so I can't go out. It's just a pouch. And then I have this tube that goes out to umbilicus. And I have my bladder. And then I have my mesonephric duct. That's what this is. Mesonephric duct. Okay? And so from my mesonephric duct, I actually grow something else. And that is what is very important, because this is going to become the adult kidney eventually. And what this is called is a mesonephric diverticulum. So we have one tube, we make a second one, and so obviously we're going to call this a diverticulum. This is what it is. So what this tube does is it comes and it's going to make another tube. So here's my second tube that comes off of this one. Then what happens is I have this space in between this, and I have this cluster of mesoderm, which mesoderm, remember, is the remnants that make up muscle and bone. And so muscle and bone tissue, this mesoderm, wants to come in and stick to this second tube. And this tube wants to come and meet at this point. And so they come together and they fuse together. This is going to be all the parenchymal tissue, parenchyma, of the kidney, and the first part of the tubules. And we'll be discussing those in just a second. And then this big second tube that we made off of this one right here, is going to be all kind of your collecting ducts, your distal convoluted, and your loops of Henle. And we'll be discussing that as well in kind of a little bit more detail. But that's actually what happens here, is that we make the tubes that comes up into the kidney to make your tubules, and then we have all this parenchymal tissue to make like your blood vessels, your glomerulus, your proximal convoluted tubule, those sorts of things. So tubule meets tissue, and now you have a kidney and its ureter. So if I were to say what is happening here, well, this is going to be most of your kidney function stuff, and then this is most of your tubule stuff, including your ureter. So now if you look at this, if I had your blood filtering into this little kidney, it flows into the tube, flows into the last part of this mesonephric duct, the old original one, and then it goes right into the bladder. So if you were to describe what is this, it's a kidney and a ureter that goes to a bladder. Isn't that the normal anatomy of the genital urinary system? Absolutely, you're absolutely right. And when this baby is born, this goes away as well, and I just have a bladder sac, and then eventually this disappears and breaks through the skin, and now I have my urethra. And this is actually exactly how the embryology is formed in here. But remember, I will show you this actually in another picture. We have another tube that kind of runs along with this. And very early, we have another tube, and this is called, this is attached to your GI tract. And so what we need to do is actually get in here, build a little wall in between the bladder and the rectum, so then the rectum can have just poop in here, and then the bladder can just have urine that comes out here. And that's an important part of development. And let's talk about that actually on our next slide. But this, I want to show you further detail. So we had our tubule that came up, our second one, our big mesonephric duct here. And then from here, we had another tubule that came up. Here's our second one. And then this is going to meet my tissue. And what this is called is my metanephric blastema. The second name for this is actually what this metanephric mass of intermediate mesoderm, we've already described that it's mesoderm. And we already described that it's meeting your metanephric diverticulum. So just put those two words together, and that's actually describing what this tissue is. So we're combining these together. So let's zoom in right here, what's happening between the tubule and what's happening between this mesoderm tissue, or what will then form your interstitial cells and some of the proximal things. So let's actually zoom in on this. So this is where your tissue is coming from. That's this right here. This kind of pink area. And in your pink area, you have blood vessels coming off the aorta. So you can see these kind of forming right here. And then what happens is I have a mesonephric duct, this guy right here, and that gives off another tubule, and this other tubule goes into the kidney, and follows and meets up with that tissue. And so you can see this part right here. So this is the mesonephric duct. We did a cross section through it. It gives off the mesonephric diverticulum, comes up as a second tube, and then it ends and it meets at this point. So we can see that this is going to be your Bowman space. This is going to be the meeting point from the mesoderm tissue. That's your glomerulus. And now you have your intact nephron. And that's everything that we're trying to get at, is what original basic embryology structures meet to make our nice things we know from nephrology and neprophysiology. And so if I were to do this a little bit more in detail, now that it kind of developed, I have my mesoderm that made my blood vessels, and you can see that here. And then my mesonephric duct was here, and that continued as my mesonephric diverticulum, and that will then make my Bowman space. And so you can see this meeting point. So this is a tube, and this is all the tubules of your nephron, goes out into our collecting duct. That's going to go into the calyces, calyx, and then that will go into the renal pelvis, and that's going to go to the ureter, and then that's going to go to the bladder, and that's the flow of urine in a normal adult human kidney, or just a baby's kidney once it's developed. And so this is kind of important to know, okay, what is the part that we end up making from this? And so the mesonephric tubules, this one right here, this is going to go all the way up to the Bowman's capsules and the renal tubules. And then the mesonephric duct itself, this original tube, this one right here, this actually then forms all the later stuff, the collecting ducts, the calyces, the pelvis, and the ureter. So all this is this stuff right here. This last piece, once they meet together, and then eventually this more proximal part of your mesonephric duct disappears. We keep the end part of this, and then the attachment, and now we have our kidney, ureter, and then we'll have our sac of our bladder right here. So hopefully this should make sense, far more than hopefully your embryology lectures probably pointed out. They probably just have a bunch of pictures and they're like, that's the glomerulus, that's the glomerular capsule, that's the mesonephric duct, mesonephric tubule, afferent glomerular vessel. And you're like, okay, and how does this make sense? Well, that's how that makes sense, is right here. Okay, so I always have this kind of basic analogy. I know you're probably going, what is this stuff, sleeping bag? So just think of that I have this tubule here, right? So mesonephric duct, I'm going to draw this really quick again, mesonephric duct, diverticulum, another tube, and then we have this kind of bag. And so if you've ever gone camping and you've had one of those stuff bags, like when you're for your sleeping bag, if you have your sleeping bag and you just kind of shove it into a bag to close it up and take it home, rather than having a flappy open sleeping bag everywhere, you just have it in this little round kind of package. Well, this is your stuff bag, so stuff bag. And this is going to be all your parenchymal tissues and glomerulus. And then all you need to do is take this tubules and we need to shove it into this bag. And so this will become your collecting ducts and your distal convoluted tubule. And then this is going to be all the remaining tubules all the way up to the Bowman's capsules. And now that's inside of this kidney. And that makes sense, right? And then the last part of this will be continued as the pelvis and ureter and stuff like that. I just want to show you that we shove all this into the kidney, similar to how we take a sleeping bag and put it into a stuff bag. We kind of bring all these things together inside the kidney. Okay, so we talked about this very briefly a couple slides back, how we have this kind of sac. This is the allantois right here. So this is our premature bladder, this yellow thing, and it goes out to the umbilicus. So if this stayed open, the baby was born, urinating out their umbilicus. Why? Because you have a patent urachus, or also called a patent allantois, is how we would call that. The whole giant yellow thing that you see on this picture is called your urogenital sinus. So they could also say that. Why is this open and urinating out of their umbilicus? Because urogenital sinus has not closed off. But remember what a sinus is. So if I have skin, right, and behind it I have a cyst of fluid, this is called a cyst, which makes sense. Okay, if I have tissue and it comes into a blind-ended pouch and it has some fluid, this is called a sinus. And then if I have an epithelial type here and it continues down, I'm going to have to redraw this, and then it continues, maybe it forms a little pouch, and then there's an inner form like this, and it continues to, oops, it does not want me to draw this. Okay, if it connects from the outside to the inside, then this is called a fistula. Correct? Yes, absolutely. So this is an open on one end, goes in, but doesn't really open on the other end. And so this is called a sinus. And that is the way the ureter is originally set up. But then we also have this GI tract kind of attached right here too, which kind of ends at this sinus as well. So we kind of have just this bag. And so what we need to do is divide the urine from the poop. And that is exactly what's happening in all these pictures, is we're taking this urorectal septum, which is this kind of purple tissue right here. And this is just dividing the bladder here from the rectum here. And it goes equally. So if I were to look at this from like head on this direction, I'd be looking at it like this. I'd have this big giant opening here. And this is bladder, or where bladder is going to be, and I have rectum. Okay, normally what we want to do is end up dividing it just like this. So bladder has an equal opening and rectum has an equal opening. However, for some reason, so this is posterior anterior. For some reason, if we have a thing where the bladder outlet and rectum outlet is more posterior like this, then that could cause pathologies. Now the rectum is narrow, the person's going to have constipation, no passage of poop when the baby is born, called meconium. Other things like, if we also have narrowing of the urethra, so maybe more anterior, and this is more posterior division of this urorectal septum, that can cause different pathologies. And we'll talk about that in just a second, actually. And so it's very important to know that these kind of developing structures, so here's our mesonephris right here, which is going to eventually kind of almost disappear a little bit. Unless you're the female reproductive tract is important for this. But we also have from the bladder, we have our urogenital sinus, or diverticulum, mesonephric diverticulum. From that, we make and form and stick to our blastema that we were talking about, make our kidneys, and that's attached to the bladder, just like our ureter is going to be, which is this yellow structure down here, right? And then we can urinate out the urethra, and the rectum is going to be divided from it and can poop out that way. Okay, so some of the pathologies that we're going to kind of talk about, just a few kind of definitions, and this is more of the high-yield, here's a picture, what is it, sort of, and I will be circling the ones that are more high-yield than others, but keep in mind that they could show you any of these images and get them. So I actually had 2 questions on this on my anatomy exam in turn 1 when we study this stuff, so keep in mind that it is high yield to know. So here we have a bladder. So what we did a CT scan with contrast, and when we put the contrast in, it obviously filters into the kidney, down in the ureter, and then down in the bladder. And so I can actually see that when I do a CT scan, and this is a three-dimensional reconstruction of a CAT scan of the urogenital system. And so when I put that in, I can see that I have my kidney, I have my ureter, everything looks fine there, and it goes into my bladder down here. Now what happened is obviously I don't see a ureter and I don't see another kidney here. And so what is this described as? This is called agenesis. No formation is what that means. And so I'm missing a kidney, so I have renal agenesis. How this happens is, remember how we talked about that meeting point between the tube and that mesoderm tissue, like this guy? If this does not happen, if they do not meet, then the whole thing disappears and goes away, and that's how you get renal agenesis. And we'll talk about that as far as definitions in a couple slides. Then we can also have patients that have not just one kidney, not just 2 kidneys, but actually multiple of them. And this is called multinumeral kidney. And how this happens is when we have actually that diverticulum, when we get this off, here, we actually form another second tube off of this one. So you can see how that ureter comes down here, and then this one plugs into that ureter to go in on this side. And then we have this third kidney over here on its own. And so that we'll talk about the definition of what causes that and come back to the picture. And then here we have something called a horseshoe kidney. So if you've ever played that horseshoe game where you have that little pole and then you throw the wonderful horseshoes at that, and it's a really hard game, but that's our horseshoe game, right? So when you throw that on here, so here's your horseshoe. And what happens pretty much is you develop kidneys normally. Here's our normal kidneys right here, normal kidney here. But then for some reason, the inferior pole of the kidneys actually end up sticking back together. Whoops, sticking together. And you might be looking at this, okay? You might be looking at this and go, something is sort of weird, but maybe not, like quite obvious. So this kidney, for some reason, just disregard this picture. We're looking at it at a wrong angle. But this kidney right here is kind of showing the normal position of the kidney. It's around, again, remember the 11th and 12th rib. It should be actually higher than this one. We're just looking at it, again, from a downward angle. But 11th and 12th rib is where our kidneys should be found on elevation. But what happens with someone that has horseshoe kidney is the kidneys develop down here, and then they rise upwards. They come up to their normal position. Well, if they're hooked together, then we've pretty much created something like a little latch point in this middle. And what this ends up latching on, and it stays sort of in the pelvis or very low abdomen, it actually hooks on your inferior mesenteric artery. The kidneys actually get stuck to the inferior mesenteric artery and do not ascend into the normal position in the abdomen. So you'll have low kidneys, one's attached to the inferior pole. That's your horseshoe kidney. This is, you can, sometimes it's just a random case, but sometimes it's an increased risk in patients with Down syndrome. Okay, next is sort of different pathology. We'll come back to D in a second. But E, the last thing that you need to know is if I have a duplication of only the last portion of my mesonephric diverticulum. We talked about this for the other place, and then keeping one of our blastemas. So what happened with the multinumerary kidney is that we divided this and made new tubes, but we also divided our blastema into 2 different pieces, and so that's why we had an extra kidney. Here we just have 1 blastema, and we have 2 diverticulum coming off of there, and that's how we get this bifid ureter, which is right here. The only thing that's really important is that if this person develops stones, it's a lot narrow in each of these places, and this is another constriction site that stones can get stuck in this area. So just remember that. And then lastly, we have our polycystic kidney disease. I know it's really gross in these pictures, and that's why I actually put this, but this is a normal kidney. This is a normal kidney size. So you can see with someone with autosomal dominant polycystic kidney disease, that this is what you can see is very large kidneys. These cysts actually derive from collecting duct cells. And so I can ask you what embryological thing from that is, but that is definitely not important. Just remember, if you see very cystic presentation in kidneys, this person might have hypertension and maybe abdominal pain, because some of these rupture and squirt some of the blood into the abdomen. I know, ew, Clark, why would you say that? But yes, those are kind of the presentation of this, and it shows in adulthood. There is an infant form, but usually those children don't survive past a year of life unless we give them kidney transplants. Okay, so here's kind of the definition of the past few slides. Obviously, if you want the PowerPoints, go to our Facebook page. You can download it from there. But we talked about renal agenesis, and that's your ureteric bud does not form. And then your supernumerary kidney, that's you get 2 ureteric buds that are fusing together. So that's like the 2 diverticulum with the 2 mesoderms. And then horseshoe kidneys, we talked about those. They fuse together, and then they get stopped. And forgive me, that should be inferior mesenteric, not superior mesenteric here. Okay, that's not true, okay? Because normally it's under the superior mesenteric, but stop under inferior. I will fix that for your slides. And then polycystic kidney disease, we talked about that as well. It's a hereditary disease. There's dominant recessive. This is infant type. And then it forms from collecting ducts in the nephrons and can cause renal failure, hypertension, belly pain, stuff like that. And then bifid ureter, we talked about that as well, incomplete division. And that's your diverticulum kind of dividing inappropriately. And that's how you get that ureteric bud flipping and making 2 ureters. Last things, once we've now made our kidneys, we have our normal position in anatomy, let's talk about a couple of the clinical things. And where that really kind of comes down to, obviously kidney stones, you're going to learn a lot about in physiology and in pathology, and you're never going to hear the end of kidney stones. So you'll have plenty of practice before STEP, doing lots of practice questions, lots of cases, lots of things to talk about for kidney stones. So I'm not going to really talk about that here as far as the pathology of each of them or whatever, but I'm just going to talk about where the stones get stuck. And when they get stuck, where's the pain go? And then just one last thing. So we have a couple nerves from our lumbar plexus, such as subcostal, iliohypogastric, and ilioinguinal, that supply different parts of our abdomen up here and stuff, and then they come down here. And so if I have a constriction in an area such as the origin, which is the place, this kind of proximal ureter, pelvic junction, so the renal pelvis to the ureter junction is very small. It's kind of a change in size, a very large pelvis to a very small ureter. So this original site, if the stone gets lodged, you're going to have a subcostal. So this is going to be actually just under the ribs is where this person has pain. So they'll be like, oh, I have upper side of my abdomen pain. And then as it comes down, the ureter, so we have this bowl of the pelvis, the ureter comes down and hits this pelvic brim and then comes over to the bladder, which is right here. Okay, so it's like posterior is anterior. So the ureter comes down and has this restriction site. This is hitting the pelvic brim. This is going over the common iliac arteries, right, which run right here. And this, if the stone gets lodged there, it's going to cause pain in your iliohypogastric, which is just a little bit lower. So it's ilium and a hypogastric region. So in this kind of zone is where they're going to have this pain. So kind of almost suprapubic, but a little bit higher, just under kind of your belly button here. And then lastly, as it goes into the bladder, this is a constriction site as well because there's a little bit of an angle there. And kind of there's a sphincter there as well. So that's going to cause a stone to get lodged there as well. And that's going to be called, or refer pain to your ilioinguinal area. And this is kind of the pain down here in your inguinal region. So lower pelvis, pretty much. And then the stone will pass in the bladder, and then they're going to have kind of urethral pain as they try to get that out if it doesn't dissolve. And so that's pretty much the areas of pain. The last thing is where the traveling of the ureter also goes. So as it comes into the bladder, there's one blood vessel that actually runs right over this, especially in females. This is the more important part to know, is I have a uterus right behind the bladder. In females. And so in females, we have blood vessels that come in and run across this into the uterus. And this is called, can you guess? Uterine artery. Wonderful pelvic arteries, always name where they're going. So the uterine artery is something that's carried in your transverse / cardinal ligament. And we talked about this in our pelvic section. So the transverse and cardinal ligament carry your uterine artery, and it's a very strong ligament to hold the uterus in its place so it doesn't prolapse and kind of come out, which is kind of gross. But anyways, so the uterus is there, and we have our blood vessels that flow right over that. And so we would call these uterine arteries a bridge. It's a solid bridge of vessels, and it's also in a ligament. So the bridge is the ligament with vessels, plus uterine vessels. Okay, and then under that we have a ureter that runs under that, and this is going to be your ureter, and we would call this water. And so they give this dumb phrase, and I don't know why it's that important, but this is the water under the bridge. Okay, so instead of going, oh, why is this important, let me give you the actual question you're going to get, if you will get one, about this. So I have a 47-year-old female that comes in, and she's done with having babies. And so what she does is she goes and sees her OBGYN, and they schedule and perform a hysterectomy. If you don't know what that is the removal of the uterus. So how do we remove an organ? Well, what we need to do is we cleave and cut off the arteries, the bridge. So we need to cut this bridge down. And when we cut the bridge, now the uterus no longer has blood supply. So if I were to cut out the uterus, it's not going to bleed all over the place. Then I cut out my uterus. So I cut off the blood supply, then I cut off the uterus, and we remove the organ. So after hysterectomy, suddenly she has, on day two or 3 or whatever, post-surgery time, sometime after that, she has abdominal pain. And it kind of is found in her ilioinguinal area, so like lower pelvic, kind of pelvic area. And it says it's kind of hurt, it's sharp pain. What happened? Now, please think of this logically as to what's located in anatomy and what causes a lot of pain. Similar to stones, so we talked about all these areas, and similar to this presentation. Well, we cut the bridge, which lays right on top of the water. So if I cut a bridge with nice sharp scissors and knives through this little surgical thing, I remember we don't have our hands really in there necessarily. Sometimes we do it laparoscopically, so we're using like robots or sort of like that. We're kind of poking around in there. So when we cut off these arteries, we can actually damage the ureter. And so this person might be leaking urine actually into their abdominal or pelvic cavities, and that's why she's having pain. So look for the answer of damaging the ureter. You're going to get this over and over and over and over every time you get to a renal question that asks you about anatomy. It's going to show up on your BSc 1 and BSc 2. It's going to show up on all your NBME practice for step 1. It's going to show up on your UWorld practice for step 1. And then it's also probably going to show up on your step 1 itself. So this is actually a super high yield concept of knowing where these constrictions are. General pain areas, that's not that important. But knowing this water on the bridge for some reason is super important and very high yield for examinations. All right, well that completes this video on kidneys and the other abdominal organs found here as we were discussing. So thanks for watching. Don't forget to subscribe. Again, if you want those PowerPoints, check out our Facebook page, CK Med, and you can download those there. All right, happy studying.